CPD registered diploma, and SAMA then submits it to the HPCSA, where it's loaded onto your profile at the HPCSA. Some housekeeping: please make sure to mute yourself. Use the chat box if you have any questions or queries. We'll try and get to them. If not during the course, then as soon as we can after the course, we can take some questions. Over to you, Razik.
Sorry, so you can see my screen?
We can see it clearly now, Razik.
Thank you and welcome everybody. Sorry, you guys can hear me now?
Yeah, we can hear you fine.
Thank you for this opportunity to talk to you this evening about uncontrolled asthma. Unlike the poster that was advertised, I thought to modify the topic a little bit to make it applicable to a broader audience. Asthma is indeed quite complicated, but it is treated all the way from the primary care level all the way up to specialist level care. And I've retitled and organized this talk to address specifically uncontrolled asthma and just do a very brief overview of the treatment options that we have available. And this is something that has evolved over the past couple of years and gives us more options in treating our patients better. And I like to say, good medicine does not necessarily mean more medicine. Some disclosures: I have given talks before for various companies that have provided speaker fees and sponsorships, but there are no direct conflict of interest or disclosures to declare. And with regards to this particular talk, there has been no industry influence on the contents of my talk. So at its very basic, and we're going to start out with something that many of you might unfortunately find a little bit tedious, but I think it's important to rehash much of the basics so that we know specifically what we're talking about. Asthma is a chronic airway inflammation. And this airway disease, the inflammation which is triggered predominantly by allergen sensitization, results in hyperreactivity that manifests clinically as respiratory symptoms that we all know about: wheeze, shortness of breath, chest tightness, and cough. And this can be measured objectively in the laboratory with spirometry, the lung function test that shows variable expiratory flow limitation, which after a post-bronchodilated challenge, we see an improvement. It's reversible of about 12% or 200 mils. And these features, importantly, vary in intensity over time. This is not a one-time disease, a one-time diagnosis, or a one-time opportunity to treat it. This little video just illustrates some of the things that we've spoken about, specifically the inflammation of the airway that leads to the hyperresponsiveness. And at the level of the smaller bronchi and alveoli, there are bronchospasms, swelling, thickened mucus, and this is mediated by an inflammatory milieu of cells and other mediators that drive this process. Severe asthma generally does not respond to the typical treatments that we give to our patients, and if left untreated, recurrent exacerbations can lead to irreversible remodeling of the airway, driven predominantly by the eosinophil and eosinophilic level type inflammation that then complicates this disease. And though asthma is easily recognized and has been for millennia, it really is an umbrella term that encompasses various airway inflammatory changes and underlying pathophysiologies, as that video showed, that exists in an evolving environment of genetic, environmental, and behavioral factors. And the allergic-driven respiratory disease exists outside of the lung as well and can coexist in the nose, in the throat, and its presence and lack of treatment can contribute to the asthma syndrome and failure to achieve control. COPD is another inflammatory airway disease. The changes in that disease result in fixed airways. And all these diseases can worsen with time. And it's important to recognize asthma in the context of this united airways, as untreated nasal and sinus disease can affect the asthma severity and response to treatment, as I mentioned. So asthma is a chronic inflammatory airway disease, and the main rationale for our therapy, and this is oversimplifying it a little, is to treat the underlying airway inflammation. And the mainstay of our treatment is inhaled corticosteroids, which target the inflammation. And there are benefits to using inhaled corticosteroids over oral corticosteroids, or in the old days, IM corticosteroids, because steroids are not without side effects systemically, and that is important. Coexisting with this inflammation, which is predominantly eosinophilic, is the airway dysfunction of hyperreactivity and bronchoconstriction that manifests aspects of our disease. And in comparison with COPD, I think it's important to highlight again that in COPD, the airflow limitation is fixed because of structural damage that has already occurred to the airway. And our philosophy of treatment is predominantly bronchodilators, although exacerbation prevention and optimization is key. And in asthma, the presence of this reversible airway disease, driven predominantly in most asthma by eosinophilic airway, is the focus of our anti-inflammatory treatments. Now, guiding us in this year is a bevy of evidence-driven strategies and guidelines, and most important to us is the Global Initiative for Asthma, an international organization that does research and analysis on the quality of that research and provides the strategies that inform our local guidelines. Our own local guidelines have been recently updated, and I encourage those that are interested to follow this link at the African Journal of Thoracic and Critical Care Medicine, where newer treatments have been updated. The United States has similar kind of programs derived from GINA that incorporates their own local factors, and theirs is promoted by the National Asthma Education and Prevention Program, or NEP. Now, this is a short video that we're going to play regarding what it looks like at the far end of severe asthma. Someone having severe asthma attack, emergency room admission, status asthmaticus. Clearly severe bronchospasm that is quite distressing to the patient. And despite nebulized bronchodilators, this impending sense of doom. And sometimes this nebulized therapy is insufficient to work because the airway is clogged by mucus that reduces the efficacy of the inhaled agents. They cannot actually reach the smooth muscles to cause the bronchodilation and relieve the airway constriction and air trapping. In cases like this, it may then become necessary to escalate our therapy. It is quite a pressured and scary environment, and the use of intravenous drugs, maybe even intubation, may become necessary. If the drugs do work, the airways shown on this bronchoscopy open up nicely, and the patient experiences relief. Now, I'm going to move on. I think it's important that we address what is meant by uncontrolled asthma in comparison to what is severe asthma. And the usual terms that we might use in day-to-day language are not applicable here. And it's important that we define these terms. Uncontrolled asthma is asthma that is symptomatic, and these symptoms can be assessed by various symptom analysis tools, shown here out of GINA as one of the assessment tools, and it focuses predominantly on an assessment of daytime and nighttime asthma symptoms, the need to use your reliever, and limitation of activity. But equally important, uncontrolled asthma is a risk domain that places the patient at risk for future exacerbations. And these future exacerbations and risk can be assessed also by the tools that are here. And this is a review comprehensively of the history, medications that the patient may be on, like beta blockers, the co-presence of those other medical conditions that we mentioned, like chronic rhinosinusitis, reflux disease, whether the patient is smoking or not, past history of exacerbations, and other factors that we will go into later. It's important that to note that having any of these risk factors increases the patient's risk of exacerbations, even if they have few asthma symptoms. And this is why it's important that even if you are mildly symptomatic, you could still also have uncontrolled asthma. The symptom assessments can be done in various ways. The simple screening tools that we just showed. We can use the categorical simple tools that have been developed by various groups, the Royal College of Physicians, 3 questions. They all generally encompass the same thing as an assessment of symptomatology regarding difficulty sleeping, daytime symptoms, activity limitation. We prefer the numerical asthma control tools such as the Asthma Control Questionnaire and more specifically the Asthma Control Test, which is a validated, simple piece of paper that you can give to your patients when they come to visit you. They then fill it in, a score is calculated, and based on whether that score is between 20 and 24, then they are on target. 25 is obviously excellent, and anything less than 20 shows that the patient is not controlled from a symptom point of view and requires an adjustment of their therapy. And as mentioned, our preferred tool is to use the asthma control test. Uncontrolled asthma that is controlled can clearly become uncontrolled. This is a dynamic disease that changes with time. And there could be multiple reasons for why the patients then go on to actually become uncontrolled. The most common stuff is that, like anyone, we are human. Patients start to feel better and then they stop taking their medication. Viral triggers, especially RSV, changes the response of the airway. And this is equally important in young people with asthma as it is in older people with asthma. Seasonal variation in Johannesburg, not as bad, but in other parts of the world where there's high pollen load seasonally, these can be the triggers that take controlled asthma and make it uncontrolled. And obviously, against the background of worsening health status, generally unhealthy high lifestyle, development of obesity changes the inflammatory milieu in the airways and the sensitivity that leads on to the disease. As a result, it's important, therefore, to continuously assess symptoms, adjust our treatments, and review the effects. Eyes on the road, so to speak. And it's necessary to respond to any hazard or events that come across our path. Specific focus needs to be paid to adherence and inhaler technique, because these are often the most common cause for uncontrolled, and they are the easiest to remedy. Now, severe asthma then is the term that we use to describe patients with asthma that remains uncontrolled despite treatment with a high-dose inhaled corticosteroids in combination with a long-acting beta agonist, a LABA. And you'll excuse me that somewhere along the talks, we use the parlance of LABA and LAMA and SAMA. And where necessary, I will spell that out. But ICS, inhaled corticosteroids, and LABA, in combination possibly with a leukotriene modifiers such as montelukast or theophylline, an old drug, or if the patient requires oral systemic glucocorticosteroids for half of the previous year to control their symptoms, then this is defined as severe asthma. But you could also have symptom control, and the term is also used to describe asthma that requires such treatment in order to remain well controlled. And as such, asthma severity is the intensity of the treatment necessary to control, or intense treatment that fails to control the disease, and not the way that it is normally used. Now, Gina provides the stepwise management that we may, some of us may be familiar with, and severe asthma is defined those on step 4 and step 5, who are on medium high dose inhaled corticosteroids and long-acting beta agonists, or additional therapies such as tiotropium and other drugs, or require low dose oral corticosteroids to control their disease. Now, what exactly do we mean by high dose and low dose inhaled corticosteroids? As a comparison, this side note is just a diagram that quantifies that dosage. As an example, the typical Butaflam that we use in 100 micrograms, if it were used as 2 puffs twice daily, that would come up to about 400 micrograms of, and would be considered a low dose. But beclomethasone, such as Bec-Ease, at the same dosage of 100 micrograms at 2 puffs twice daily, would give us a dosage of around 400 micrograms. And with regards to this agent, it would then be considered as a high dose inhaled corticosteroids. And this is due to the different potencies of the corticosteroids and the pharmacodynamics and dose responses of these specific agents. Now, why is any of this important? Well, asthma is a huge problem globally, with over 350 million people suffering from it. And it adds immensely to the health costs, let alone the impact that it has on the mental, emotional health of our patients, their ability to work, and their personal relationships. Now, South Africa is famous for many things, and we're top of the world. This is something not to be proud of. We rank #1 in the world for asthma deaths per capita. And there may be multiple reasons for why we have this infamous accolade. Locally, over 3 million South Africans have asthma, and 5% of them are classified as severe. This strains our already strained healthcare system and drives up the cost that we've mentioned. And perhaps at the heart of our specific asthma epidemic and its poor control is a suboptimal management by overuse of the SABA reliever. And as I mentioned earlier, SABAs treat the symptoms, but leaves the underlying inflammation unaddressed. And as I showed in that diagram regarding COPD and asthma, the focus of an asthma has to be on treating the inflammation. And giving patients symptom relief is a false reassurance when they can actually have very severe inflammation. And this is what drives these presentations in the emergency room of near fatal and in some cases severe fatal asthma. And this obviously increases the risk of hospitalization and mortality. Now, these GINA guidelines that I mentioned have evolved over the years. It was founded in 1993 by the World Health Organization and some American institutions. In 1995, they introduced the GINA stepwise management that I briefly showed in one of the slides. In 2006, as we have already taken the time to define, they had this management approach based on control, defining specifically what we mean by control and severity. Subsequent to this, in 2014, the guidelines incorporated local population recommendations because asthma is a different disease in different parts of the world, specifically in high-income countries and in developing low and middle-income countries. In 2019, and because of this infamy that we have in South Africa of SABA overuse, it was necessary for GINA to explicitly state that SABA use on its own, mono-SABA therapy, short-acting beta agonists, and by this I mean the Barotex, salbutamol, and less likely these days, the Ipvan, ipotropin, and it should no longer be used for the first stage. So much so that last year, and then now in this year, the Global Initiative for Asthma introduced these tracks that include a combination of inhaled corticosteroid and a rapid onset beta agonist, and in this case, formoterol, as both maintenance and reliever for patients that have mild or what is considered mild asthma on step 1 and step 2. And it's an interesting thing because by using this here, you address the inflammation. In fact, some calls have been made that we should never allow SABAs to be sold in the market without them being combined with inhaled corticosteroid for this specific reason. Moving on, the uncontrolled asthma. What exactly is it that we can then do? Well, the basics: optimize adherence, check the inhaler technique, and address this by training or appropriately choosing a modality of how we give the inhaler. This could be a pressurized meter dose inhaler with or without a spacer, or a dry powder delivery system. And remember to treat the whole patient and the coexisting diseases that we've mentioned. And remember the United Airways respiratory system is a continuous, embryologically similar structure from the nostrils to the alveoli, and even the esophagus and the stomach are embryologically related. And coexisting gastroesophageal reflux disease in particular, if it is present, needs to be diagnosed and treated. Now, the inhaler technique is actually the one that is most common, and you guys have probably seen this little clip that I'm going to show before. It's a little tongue-in-cheek. It is fictional from one of the popular TV programs, but it highlights very much that if you don't ask and don't have it demonstrated to you, you really don't know how badly our patients are using their pumps.
My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes, Anna. You need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
For those that are listening, if you do have questions along the way, please note them down so that we can address them at the end of this talk, because the discussion will be a lot more fruitful than just listening to this. Or in the meantime, you can enter it into the chat so that we can start preparing a response to some of the questions that you might have. So now, having gone through this process of assessing uncontrolled asthma, optimizing the basics such as adherence and inhaler techniques and the other things that we've mentioned, and finally confirming true severe asthma as GINA step 4 and step 5, what do we do? Well, why is this asthma severe? And Very briefly, an apology for repeating, asthma is a complex heterogeneous disease. It's a syndrome that arises from genetic factors interacting with the environment and the treatments that we give across time. And this results in your specific patient's disease presentation. Now, we'd like to talk about phenotypes and endotypes, and what exactly do we mean by it? Well, the asthma phenotype is what you see, what is physically obvious to you in a clinical consult, and it's the observable characteristics. And this might be patients who have asthma that frequently wheeze, patients that are frequently productive of cough. We use the same thing to describe bronchitic COPD. The endotype is the specific biological mechanism that underlies this. And there is not always a direct correlate between how the patient presents to you and what the underlying biology is. Now, there are symptom-based phenotypes, the exacerbation prone that we mentioned, the cough variant asthma, and others. There are trigger-induced phenotypes that we can describe, such as exercise or aspirin, which is quite common, the seasonal asthma. And then more important to us at a specialist level, and because we have access to these tools that may not be available in the GP practice, is biomarker-based characterization of these types of asthma. And for those of you that remember, we used to speak about steroid-resistant asthma, patients receiving high-dose inhaled corticosteroids, even oral corticosteroids, and despite this and proven compliance by direct observed therapy, remain resistant. And this correlates to a certain extent and may be an indicator that you actually have a non-steroid responsive inflammation, such as neutrophilic asthma, shown in the slide. And then diving deeper into it, well, the severe asthma phenotypes, whether it is driven predominantly on allergic pathway, the so-called type 2, either as an early onset asthma or late onset asthma with eosinophilic predomination, underlies has an endotype that can be useful in us then choosing specific therapies shown by biomarkers. And the reverse is equally true, that you have a non-type 2 allergic, non-allergic driven asthma, and our approaches to that would then be different. Now, severe asthma has different types of underlying inflammation, and just very briefly, the eosinophilic and non-allergic eosinophilic inflammation that we are familiar with. These are the two things on the upper left and the upper right, and other types such as non-eosinophilic asthma and specifically non-T2 Th1 driven neutrophilic inflammation showed in the lower right-hand side. These are the ones that tend to be steroid resistant. And there is an underlying pathophysiology which is complex, it is incompletely understood, our understanding of it is evolving. And this basic science is not just for sport, because the hope of doing all of this is that it will translate into clinical practice management decision-making to improve our patients' outcomes. This is just another diagram. This one here, like the last one, attempts to sketch the lay of the land, so to speak, of asthma. But included here in white are some of the therapeutic options of the newer drugs that are available to us, the biologics, that can target specific underlying molecular mediators and cells that may be useful in our very severe uncontrolled asthmatics. Now, how do you know? The allergic eosinophilic inflammation, the non-allergic eosinophilic inflammation that our patients have? Well, the answer is biomarkers and phenotyping through the use of the biomarkers. Now, sputum eosinophils are historically and conceptually the most direct measure of airway inflammation because of the eosinophilic, but it is difficult to do, and the correlation with disease is actually quite variable. Blood eosinophils and other blood tests are surprisingly easier to do and correlate well with a degree of underlying airway inflammation driven by eosinophils. And obviously IgE is key if we were to then use anti-IgE therapies such as Xolair. Pheno, which is a favorite of mine, but not readily available, requires a bit of experience to interpret correctly. And there are other biomarkers that exist, but they've yet to find specific clinical utility, and it's not something that I expect to see in clinical practice or in the guidelines anytime soon. Now, asthma has, in the vanilla run-of-the-mill asthma, generally an increasing of symptoms with increasing eosinophilic inflammation. But these other phenotypes and endotypes that we spoke about, especially the obese non-eosinophilic asthmatic, smoking asthmatic, don't follow this here. And these ones show variable responses to mainline therapies that we may give them. So what to do? Well, again, as I said, better medicine does not equal necessarily more medicine or newer drugs. Use the existing drugs that we have better. And the inhaled corticosteroids with our long-acting beta agonists and our ultra-long-acting beta agonists for prolonged bronchodilation in combination with a long-acting muscarinic agent. This would be things like tiotropium, Spiriva, Forvent, that many of you are no doubt using in your COPD patients, and which is the longer-acting version of the old red pump, the ipratropium bromide or Ipvent. And hopefully more recently, Novartis in particular will have a single inhaler triple therapy that will be available to us. And then depending on the underlying pathophysiology, endotype that a patient has, the use of macrolides for their immune modulatory effects in neutrophilic type asthmas can be used. And we should use biomarkers for phenotyping, and by using them at a GP level practice to a certain extent, we're doing eosinophils, but more at a specialist level practice. And this will help us to phenotype and to titrate our dose. It's a little distressing that asthma, in the burden that it has and the cost that it drives, is treated less than diseases such as heart disease and diabetes, where at primary level care, you will have your cholesterol tested, you will have your HbA1c or fasting glucose assessed. And these tools then guide early diagnosis or preventative medicine for those type of diseases if you are at risk. But when it comes to asthma, you're lucky if you're going to get a lung function test, even non-bronchodilator at a primary care level. In cases of severe asthma, where we are using drugs that we have trialed and they no longer work, we should cease them because of unnecessary drug-drug interactions and side effects. And then obviously biologics exist as an option that can be used at the very highest end. Please don't forget the non-pharmacological therapies that exist. An educated, well-informed patient with an action plan and those that are vaccinated and living a healthy lifestyle do better. Pulmonary rehabilitation, focused on breathing exercises and mucus clearance, are minimally exploited strategies that should be considered in severe asthma management, and allergen avoidance, which, to be fair, in the real world is difficult to achieve. And again, the treatment for everything is not necessarily to give more medication. Now, there's an old joke that goes that the only thing that we can offer our asthma patients is the blue pump, the reliever, a brown pump, which is the inhaled corticosteroids, to encourage them to stop smoking, which has a meaningful impact on their disease, and allergen avoidance, and looking at the poor cat that is responsible for it. But our armamentarium has thankfully grown in the past couple of years, and we have this LAMA add-on therapy, the triple therapy, and in combination of a single inhaler to improve compliance, the use of macrolides and how to choose which patients in whom to deploy that therapy, the leukotriene modifiers such as montelukast, the use of our biologics. And then in the very extreme end and only in registry base, other interventions such as bronchial thermoplasty. And I cannot again overemphasize that patients and the viral triggers for their asthma, it is important to have annual vaccinations specifically against influenza. Now, moving on, this is the GINA stepwise approach that I've shown in the previous slides, but specifically in this one, in 2021 and onwards, GINA split it into tracks. And as you can see in step 1 and step 2, compared to the previous ones, we no longer have SABA on its own. Or if you are going to use a short-acting beta agonist, then inhaled corticosteroids must be used. The preferred track, and this is actually something that depends on the availability in local countries and the cost, is to actually have it as a combination of an inhaled corticosteroid and a rapid onset, relatively long-acting drug, formoterol, that you will be familiar with as Forotec, and this combination by drug names such as Vanair and Symbicort. And then stepping up the treatment based on the control as we continuously reassess and adjust our therapy for our patients. Now, at the very highest end, and for the focus of this talk in our severe asthma, the option to add on LABA in both tracks is key to improving, as an option, control of these patients. And again, use these existing drugs better. And we're going to talk a little bit about the single inhaled therapy that is available. Now, does this addition of LABA actually work? Now, it's more than 10 years that this study showed that in patients who were poorly controlled on the inhaled corticosteroids and the long-acting beta agonist inhaled, that the addition, in this case here, tiotropium as a long-acting antimuscarinic agent, significantly increased the time to first a severe exacerbation and provided modestly sustained bronchodilation. And again, you guys may be familiar with the use of tiotropium in your COPD patients by those market names of Spiriva or Forvent. Now, the rationale for the use of LAMA therapy is beyond simply just additional bronchodilation. There appears to be evidence of synergism between the steroid and its anti-inflammatory effects, the bronchodilatory effects of LABA and LAMA, and potentially even these long-acting antimuscarinic agents have on their own an anti-inflammatory effect. And it's something that in COPD management, we would use LAMA in place of inhaled corticosteroids in certain subtypes of that disease. Now, the single inhaled therapy that I mentioned, it makes a nice idea on paper, but does it work in the real world? This table just highlights a couple of studies that have been done in recent years, comparing single inhaler triple therapy in asthma to either inhaled corticosteroids and long-acting beta agonists, or a two-pump regimen of additional tiotropium. Now, the first 4 studies that are shown here are actually soon to be marketed as they've been registered in South Africa. Product from Novartis, one of our sponsors for tonight, the Zimbus Breeze Haler. And you may be familiar with this device because it also is available for a long-acting beta agonist, indacaterol on its own, Onbrez, and a glycopyrronium is Seebri. And these studies show. Glasgow has a drug called Trelegy, which is also a triple combination of a steroid, in that case, fluticasone furoate, a once-daily steroid, Maclidinium, which is a long-acting beta agonist, once-daily dose, and ultra-LABA, and long-acting antimuscarinic agent, and the Valenterol, which is the ultra-long-acting beta agonist that they have. Unfortunately, they have not secured registration for its use in asthma, although we are using it in our patients with COPD that qualify for triple therapy. With regards to Novartis, they went about this program of the platinum clinical development trials that were done, and as shown in the previous slide, Iridium and Argon. And these are actually very nice studies to look at in terms of how they were done and the results that were shown. But I specifically enjoyed the last line that was done in this little press release clip that I took from their website, that there remains an unresolved barrier such as treatment mismatch, safety issues with oral corticosteroids, and an ineligibility or cost availability of biologics that have created an unmet medical need in asthma treatment. So the trials spoken about show, not unexpectedly, that single inhaled triple therapy with high dose inhaled corticosteroids is more effective than those with medium dose inhaled corticosteroids. Reduce exacerbations, especially severe exacerbations. They're similarly effective when it comes to control, and there are no safety concerns. And these conclusions are in keeping with what we've been speaking about, this narrative that aiding the LAMA in severe asthma has additional benefits. Now, how would we then recommend the use of such a drug? Well, in the patients that have the uncontrolled asthma, despite the medium dose inhaled corticosteroids and LABA, but who, if we phenotype, have low T2 markers, so they are unlikely to respond to you bumping up the inhaled corticosteroid dose and would actually benefit from the bronchodilatory and non-steroid driven anti-inflammatory benefits that may come from adding a LAMA. Alternative, you may use these drugs, this particular pump and drug combination as an alternative to high dose inhaled corticosteroids and LABA. Because high dose inhaled corticosteroids carry with them significant systemic risk. For all that they are, their ease absorption and high doses over time will cause issues. In the pediatrics, there's a concern about growth trajectories. Commonly, our patients complain about oral thrush, dysphonia, easy bruising, cataracts and glaucoma, bone density, especially in our female patients, and obviously adrenal suppression. And they may also be used in uncontrolled asthma with high-dose inhaled corticosteroids and LABA before a consideration of continuous oral corticosteroids, which effectively is verboten, or biologics. There are still, however, unresolved issues when it comes to SIP therapy, and this is in which specific phenotypes and endotypes should they be indicated? Should they be used ahead of alternatives for patients who have fixed airways limitation? triple first of biologics, as we've said, and this will depend on cost and our local availability. Now, actually, let me just go back to that slide. We here at the topmost of the step 5, we have our severe asthma. We've spoken about the addition of LAMA therapy, long-acting antimuscarinic agents to these patients, but equally, it may be an option in appropriate patients for us to consider the biologic therapies that have become available. The use of the macrolides that we spoke about, or the leukotriene receptor modifiers such as montelukast, and in cases where nothing else is available, reluctantly oral corticosteroids. Now, Gina provides, in addition to the stepwise diagram, a nice flow diagram that I thought I'd show you guys as to how you go about making some of these decisions. We start with the uncontrolled asthmatic that we've up till now gone to exhaustive length to list reasons why they may be uncontrolled and optimizing them. We've educated our patients, we've treated our comorbids. We now have patients who have severe asthma, and at this point, it would be advisable to refer it on to a specialist, specifically a pulmonologist. And what then will we do? So moving on in the guideline, now we have these patients, we would investigate them further, and the pulmonologist will evaluate these patients more comprehensively, looking for eosinophilic diseases such as Sjögren-Strauss, now known by eosinophilic granulomatosis with polyangiitis. We would assess the blood eosinophils, the asthma phenotyping that we spoke about by the use of these biomarkers where available. And because one biomarker is not enough, pheno on its own doesn't work. The use of these additional biomarkers help us to make that determination at a specialist level, whether we are dealing with severe asthma, compliance confirmed of either a type 2 or a type 2 high, or a non-type 2 or type 2 low. And the biomarkers that will guide us is the level of the serum IgE, which causes the mast cell degranulation, the fraction of the exhaled nitric oxide, which correlates with the airway eosinophilia, the blood eosinophils, which correlate with the airway eosinophilia, periosteum, and some other ones. And this will then help us to make the choice of whether to use anti-IgE therapies such as Xolair, omalizumab, or the newer biologics such as anti-IL-5, anti-IL-5 receptor, anti-IL-4, IL-13 receptors such as dupilumab. Or in the cases of where patients do not have that, a consideration, if we're already not done so, macrolide therapy such as azithromycin, or in cases where it is available, the bronchial thermoplasty that we spoke about. And having exhausted this and moving on, then we would need to carefully evaluate our patients with regards to their specific eligibility for anti-IgE therapy, one of the biologics, anti-IL-5, anti-IL-4, and anti-TSLP, or thymocyte stromal lymphopoietin, which actually has maybe a use in our type low that I didn't mention earlier. And again, we may use certain things to predict where we are going, but to be fair, we've got very little experience of this because the availability in South Africa is not there. The point that I'd like to make is that there are more treatment options that we have in our sickest of patients that we can deploy in the more modern day. And then, not to overstress the point, and coming almost to the end, it is necessary that the treatment of asthma, especially severe asthma, is a continuous process of review and adjustment. We need to revisit the basics and get them right. We need to use evidence to target the type of therapies that we use and to implement them. And if we should do this, our patients are more likely to benefit and to improve the quality of life and hit their targets. Again, just a slide regarding the biomarkers that we have, with blood eosinophils being the preferred one over the other two. And then finally, and just in closing, something that we have interest in is the use of bronchial thermoplasty. Now, this is something where, as a result of long-standing asthma, the hypertrophy of the airway smooth muscle, we use bronchoscopy to actually debulk the smooth muscle mass by using radiofrequency, almost like cautery that some of you may be familiar with, that delivers a heat energy that damages and causes a smooth muscle reduction in the airway. And is a treatment option that is positioned for use in patients with severe persistent asthma, which, despite all the other optimizations we've spoken up to now, don't work. And I'm going to show a little video after this of how this is actually done, and then we are almost at the end.
With normal breathing, the airways of the lungs are fully open, as in this cross-section of an airway. People with severe asthma have more airway smooth muscle circulates. This excess muscle, together with inflammation of the airways, combines to make the airway walls thicker than normal. During an asthmatic attack, in response to an asthma trigger, such as an allergen or irritant, the airway smooth muscle contracts, leading to airway narrowing and breathing difficulties. During bronchial thermoplasty, a small flexible tube is advanced into the airway through a standard flexible bronchoscope placed through the mouth or nose. No incision is required. The Alair device has an expandable wire electrode array at the tip, and when it is expanded, the four arms of the electrode array come in contact with and fit snugly against the airway wall. The expanded electrode array will then deliver controlled radio frequency energy for about 10 seconds to heat the airway smooth muscle. About 1/3 of the targeted lung areas are treated during a single procedure. A total of 3 procedures are currently needed for complete treatment. Once the procedure is completed, the device and the bronchoscope are removed. The controlled energy delivered during bronchial thermoplasty creates mild heat within the airway wall that is designed to reduce the amount of airway smooth muscle. By reducing the amount of airway smooth muscle, the procedure reduces the ability of the airway walls to contract and narrow during an asthma attack.
So in summary then, uncontrolled and severe asthma are major health problems that need to be addressed. It's important to get the diagnosis right, to optimize the therapy, and adherence in this regard is key, compliance. The majority of patients can be managed by attentive care to simple things like the inhaler technique, the correct drug choice, and importantly, smoking cessation, especially in South Africa. Get the basics right, low-hanging fruit. Severe patients, however, should be timelessly referred to the specialist for review. And as I've outlined, and apologies for doing it quite briefly and quickly, the various steps that we would use to judge which therapies above and beyond what's available at a primary healthcare level to implement. It's also important to remember that once we have seen the patient and optimized them, motivated for these drugs, most patients with controlled asthma, long-term control as assessed with a 6-month running review, should be stepped down for care by their primary physicians. And this will give you insight into the other side of the coin of this very common disease, asthma, the severe aspects of it, and some of the drugs and techniques that we as specialists deploy in trying to optimize outcomes. Promising options exist beyond these mainstay treatments, as I've said, and this gives me, especially as a pulmonologist, a certain hope and a sense of relief that no doubt our patients will be relieved and will go on to lead fulfilling and healthy lives. Thank you for your time.
Thank you very much, Dr. Razikani. There is a very enlightening and breathtaking discussion. Lots to digest, lots to ponder about. I think the sobering thing there was the stat about us being the country with the highest fatalities as far as asthma is concerned. And me coming from the East End, I mean, we've seen how few pulmonologists are out there. So I think once again, just like the emphasis is that, I mean, the primary caregivers have to be the mainstay of treatment. I don't know, Razik, if you want to pick up on the questions coming up in the chat, and we could take them one by one from Dr. Shanaz onwards.
Sure, give me a second. I'll just try and get all of these right. So I think maybe we'll start with the question regarding mucus clearance strategies. Now, the reason that I actually highlighted this is that there is a interesting idea that the airway inflammation is driven by Charcot-Leyden crystals and the mucus as a driver. So independent of some of the allergic and the other triggers that exist, the presence of these proteins alone can actually do it. And you may be familiar with our patients with COPD, where it's important to get bronchial toilet, getting the mucus out. You guys are no doubt taught, like I was, that not everything that wheezes is asthma. The wheezing is caused by airway narrowing, and this may be the bronchial constriction that exists in our patients that have bronchoconstriction, but mucus plugging equally. And mucus plugging adds to the potential of infection taking hold, that inoculum becoming truly infective and establishing a pneumonia or a infective bronchitis. And the mucus clearance strategy is something quite simple. In early COPD guidelines, it was deprecated. And then when people were using higher doses and doing it better, and maybe to some of our allies that are part of this discussion, the role of the physiotherapist in assisting the patients in loosening up the mucus and getting out, I think, is very important. There's a question here regarding Pulmicort, 800 micrograms BD in the COVID patients. Well, not quite for asthma and whatever. Yeah, I guess there's a temptation to actually use steroids and then maybe to use too much of the steroids. The dose response curve of the various agents are actually different. I generally feel that we are using way too much in terms of inhaled corticosteroids in COVID, inhaled corticosteroids. Also, when it comes to Pulmicort, nebulizing it is not easy. You need a jet nebulizer with a high flow to make sure that the solution, which is actually not very soluble, actually aerosolizes the steroid and it reaches the airway. With regards to this, you may be familiar with drugs like cyclacenide that were posted as having the advantage that they actually don't work if they deposit in your mouth or you swallow them. They're only activated in the respiratory mucus and they reduce the systemic side effects. And I think that is important and something that we'd want to do. Interestingly, if you are someone who is receiving inhaled corticosteroids and you do have COVID, with regards to steroids in general and inhaled steroids increasing viral shedding and the impact that might have on the disease, well, bizarrely, we see that depending on whether you are an allergic Th2-driven asthma or low Th2, the effect on COVID is actually reversed. But COVID is new. And to be fair, making comments on it, proper, rigorous scientific studies are lacking, and we're still awaiting an analysis to maybe follow up on some of these ideas regarding it. From Musa Desayu, from what age can LABA be used in children? Unfortunately, I'm not a pediatric pulmonologist, I'm not entirely sure, but I think it is safe to use from 12 years and onwards. With regards to any of these drugs, again, it's important to weigh up what our therapeutic targets are, the drugs that we're currently using. It may work in some patients with minimal side effects, and in others, side effects predominate, and you need to balance the risk-benefit for that. Pediatric asthma is a little bit different. It has certain characteristics that I'd leave to the pediatric pulmonologists. Some of our patients outgrow it, and there's some nuances to it that I'm not really qualified to comment on. From Aslam Kasim regarding Zimbus, not indicated for pediatric use. I think maybe some of the representatives from Novartis can actually comment on that. Again, in pediatric, I'm not quite qualified to make comments with regards to that. And then finally, I think there's a question regarding childhood asthma that wears off as the patient approaches teenage years. Yes, and in fact, that's something that we used to talk about it. They'll grow out of it. But it's not as simple as it used to be. And maybe one of the distressing things is that you've got all these fancy smartwatches, you browse the internet and all your data is collected. We do not have good registries on respiratory health and disease. Our healthcare system is not great. Most part of the world, they don't collect this information. So it's hard to know what the true natural evolution of all these different types of asthma in different settings, high income, low income, urban, rural, exposure to biomass fuel, parasite burden, kids that are living in too hygienic an environment, if you buy into the hygiene hypothesis, the gut microbiome, the use of childhood antibiotics. We really do not have high quality evidence to make this inference. But yes, the pediatric pulmonologists often talk about, and it's been experiences that I've had with a few patients, that as they get into their teenage years, their asthma gets milder and some of them come off their treatment completely. Are there any other questions that I might have missed or questions that people would like to ask verbally?
You guys can just unmute yourself if you have any questions, or you can edit chat box. Razik, in terms of, while we wait for more questions, in terms of the biotics and treating severe asthma, how many hoops do you need to jump through for the medical aids to pay for them? Because there's also a concern in our patient population.
My personal experience has only been with Xolair, and depending on actually the type of medical aid, which specific medical aid we're talking about, I mean, there are guidelines and it is a process. In my opinion, it's not something that we just want to open the gates to, because they need to be deployed very carefully. And in general, I just don't like the bureaucracy that comes around healthcare. It leads to healthcare inequality. And being as a doctor that works predominantly in state, it really gets me that we have therapies that some of our patients will never be able to access. Equally, I don't want it that patients that have the means are using drugs that they really shouldn't, because that drives up healthcare costs through health sector inflation and other things. But no, my personal experience in Xolair, specifically the newer drugs, I haven't had an opportunity. When I was doing a bit of a preceptorship overseas in Holland, mepolizumab used in severe asthma, and here it's actually for the whole of Holland, they get referred to a severe asthma center where they are comprehensively assessed. All of the things that we've spoken about have been optimized. They even look at the steroids and try and make them ultra fine and get them deeper into the lung to work better. Then and then only would they consider the use of drugs, and they had a preference for mepolizumab over omalizumab at that time. But since then, other drugs have become available. We're growing in our understanding of how to guess ahead of time which would be the most appropriate expensive drug to trial to try and get it right with our first shot.
Okay. Can you maybe explain to us a little bit also about the nitric oxide, the pheno tests, for those of us who are unfamiliar with the test?
So historically, I mean, it's important, like I said at the outset, asthma is an inflammatory disease of the airways, a chronic inflammatory disease of the airways, and it could be from allergic and other stuff. It doesn't really matter. And if you wanted to know if something's there, go looking for it. But unfortunately, it's all inside the chest and you can't. And collecting sputum, and it's got to be a good quality sputum to look for those eosinophils, is just not practical in real life. And also processing it and doing the measurement is fraught with difficulty. But it's historically where this thing started, especially with particular Professor Peter Gibson that started this. I mean, we need to know what's going on in our disease. I mean, we've been treating it with incomplete understanding. We've grown in understanding the underlying pathophysiology and deep biological mechanisms. And that's helped us to come up with the newer drugs and to deploy them in a correct way. So along the way, certain ideas came up. Well, these eosinophils, what they do is that they cause, through nitric oxide synthetase, nitric oxide to be secreted in the airway, and there may be reasons for this here, and we exhale it. So if you could come up with a device that could measure these volatiles, and there are other volatile organic compounds that can be used. Interestingly, the future of lung cancer might be equally to have these devices that can measure volatile components that would say that a cancer is present. And maybe even in TB, the use of an electronic nose, which is nothing more than a fancy molecular analyzer through a mass spec that tells us this molecule is present, you've got this underlying disease. Well, pheno is exactly that, and it's been developed and it goes. In reality, it's difficult to calibrate. It's confounded by a number of things, other drugs that the patients are on, even whether they've eaten, whether if they are smoking. And it's not so much about what the absolute pheno number is, but also how it changes with time. Equally, you can use pheno, add steroids, see whether you get pheno suppression, and that's something that's used as well. But it has this potential of being deployed at primary level care. It's a portable device with cartridges that you actually buy. And that's why it's a particular favorite of mine. But outside of clinical studies and in some very specific centers, it hasn't been deployed as commonly as I would have liked.
Yeah. I've got an interesting question. He says that how do we get patients off their reliance on the short-acting beta agonists, with allowing over-the-counter ICS and LAVAs a possible solution?
Well, ban short-acting beta agonists on their own. Right? I mean, we need to regulate it. This is not sure, it's a business and these people want to do it, but they can't influence what is meaningfully creating across the world. I mean, in more recent years, we've actually gotten better for various reasons. There've been campaigns and education. But to be number one in the world in fatal and near fatal asthma deaths because of SABA overuse, and if you look at the numbers, it's shocking the number of people that actually use it. And you all got to understand the psychology of the patient, and especially in that clip from House MD, you know, he's a bit of an, interesting character that can be quite short with the patients. Don't do that. You know, it's important to educate your patient to be supportive. Patients don't know. We've got the benefit of medical education and having mistakes or seeing mistakes in other patients. And yeah, I hope people would spend time looking up things from reliable sources on the internet and in social media and be given the advice, but simply tell them you've got an inflammation. You're stuck with this disease for all intensive purposes. I come across the same problem in diabetes, that people don't want to take more insulin or control their sugars. And my response to them is very simple. If you don't control it, you're going to have consequences and you could very well die from it. As long as your sugar is controlled, Doesn't matter how much insulin or exercise and diet, you've got to do the things to keep it controlled. And if you don't do it, well, you're just pretending that it's not severe. And when it comes to asthma, you've got to treat the underlying inflammation, and simply doing it so that you can carry on with your life. That type of, a simple decision-making, the utility that patients do, the psychology, is not what you want to do. So you need to focus on education. You've got to take time to speak to your patients. I spoke about some of these tests, like the asthma control test that we use, simply trying to get it in local languages. So patients who do not have English or Afrikaans as their first or second language, to reliably able to read it, understand it, and fill it in correctly has been a challenge. We're not doing very well in this non-medical medicine. And that's something that the low-hanging fruit, if we did it better, I think we could turn the tide from that infamy of being ahead in the world of severe fatal asthma.
I think, we've got a bit of technology in our favor. Google Translate is now available in Sepedi and Tsonga and all of these languages. So maybe we should start using some of our smartphones for good, not evil. There's another, Leonard asks, what's your opinion on the role of once daily single inhaler triple therapies to obviously get rid of that reliance on SABAs?
So for those that you don't know, Leonard is from Novartis, and they're actually pushing it. I might have alluded to this. If you've ever had to take a chronic medication and remember to take it, to keep it in your bag or your pocket or purse, and you forget it, and this applies to diabetics, other drugs that you take multiple times a day, in general, and it's a generalization, the opportunity for non-compliance and adherence increases. It's as simple as that. And if you could give something that would last the whole day, you take it once in the morning when you remember, when you're at home, right? You have this opportunity to achieve all of those goals, good adherence, great drugs, target what needs to be done. A friend of mine interestingly said that, well, taking drugs twice a day gives you the opportunity to forget once and still get it. So you're halfway there. But if you've got a single daily dose and you take it and you forget to take it, well, then you're 100% lost for until the next dose the next day. And this is not actually entirely true. I certainly like the idea of long-acting single daily. And again, referring to diabetes, the use of single daily long-acting insulins as part of the background control changed. I remember having patients on Protophane in the old days, and now with drugs like Lantus and Webima and Degludec, I'm not sure what the trade name is. It gives you a level of control. And as a diabetic myself, that's why I keep referring to it. It allows you to be a good compliant patient, but still carry on with your life.
There's a couple of more questions coming up in the chat box.
So I see there's one that says the comment in more rural settings where clinics don't have doctors, etc., and no referral, nurses dish out the bronchodilator. And this is true. But again, that is stating the reality. We've got to come up with a solution. And we shouldn't have a certain fatalism, excuse the pun, with fatal asthma, that no, because that's the way that it is, we can't actually change it. We've got a lot of work to do. And it's not high tech, and it's not fancy, and it's not expensive. It's spending time teaching our medical students and nurses better, getting those people to do things right in the community, taking time to speak to patients. You got to love spending time talking to your patients, figuring things out, educating them in their own language, or using descriptors and metaphors, because that way you achieve better control. It's not as simple as I give it and what they do with it. That's up to them. So yes, you are entirely right. Moving the inertia historically and otherwise of overuse in a rural setting by nurses, people with more effort and more patience than me will need to address that. And is there a place for salmeterol as a controller? Well, not on its own. Salmeterol is a long-acting beta agonist with a 12-hour twice daily action. It has to be done in combination with inhaled corticosteroid. And that would be salmeterol plus fluticasone in inhalers like the Discus inhaler, the Fox Air that people are familiar with. And I see there's another question. What's your opinion on inhaler technique education and adherence monitoring programs conducted in pharmacies, which provides for an asthma action plan and referral to the patient's GP for intervention when poor control is detected? I think it's an excellent idea. If you're going to sell the drug and you're going to get profit from the drug, you got to do due diligence, right? You're going, not quite maybe in South Africa, but in other parts of the world, buy a gun, they go through a process of it. You're going to get something which can be potentially equally dangerous, just a cost driver. There should be these things that are actually done. And it takes little additional costs. It's point of contact. There should be multiple opportunities for a patient to be asked, how's your disease doing? You're using this drug. Let's see if you are hitting target. Oh, no, you are not. Here's some advice. Oh, please refer, please go to a doctor. Here, I can refer you to someone. We can do it with an in-house pharmacy doctor, whatever. And this is the type of innovation we need if we're going to improve asthma care and outcomes in South Africa.
I think we're running out of time now, Razik. We've taken a lot of your time already. Are there any more questions? While you're waiting for more questions, just to remind everybody, please join the IMA if you haven't. Join us at our convention if you haven't. We're looking for articles and speakers, Razik, hint, for our 40th convention in Durban in October this year. We haven't had a convention for 2 years, so I'm sure lots of you have lots of ideas and we'd love to hear everything at our 40th convention. I see there's no other questions. Razik, I just want to say, Jazakallah khair, thank you so much for taking your time out after a busy day to educate us on this very important subject. Lots of food for thought, lots of place for improvement, and lots of reading for us to do. I'd like to thank Novartis for sponsoring this and all our participants for taking out time on this cold winter evening to join us. If there's no other questions, then we can conclude the meeting.
Just a final note for those that are interested. I didn't provide too many references, but if people would like a copy of the talk, they can just contact the organizers and I'll provide them to a link where the file is, and you can review it at your leisure.
Much appreciated, Razik. Thank you, everybody. Jazakallah khair. Assalamu alaikum wa rahmatullahi wa barakatuh.
Yeah, so what the hell is going on here?